Welcome everyone. This is Dr. Vaibhav. We are discussing this educational series of lines and tubes in adults. Uh, in the previous session, we have discussed about respiratory system related lines and tubes. Today, we are going to discuss about gastrointestinal system related lines and tubes. This is basically focused upon FRCR shorts part of the examination, but in longs and also in the Viva, if you encounter any malposition of the lines and tubes, you should be able to identify it and report it to the examiner. That will give you extra points. Okay. Now, going further, the first lines and tubes we are going to discuss is gastric feeding tube. And I frequently tell FRCR to be aspirants that do not use this yeah, nasogastric tube, because sometimes you can put gastric feeding tube through the mouth also. So there are, if you see, if any abdominal radiograph is taken and you don't know where the tube has been put from, whether it is via the nasal route or via the oral route, so it becomes difficult to directly label it as nasogastric tube, and there you can go wrong. Okay, so that is the reason it is better to call safely as gastric feeding tube instead of nasogastric tube. So gastric feeding tubes are of two types: nasogastric tube and orogastric tubes. The uses of gastric feeding tubes are for enteral feeding, for nutrition, also for medication administration in elderly patient, debilitated patient, where oral medications are difficult to introduce to the patients, and for gastric decompression, also for removal of air and removal of fluids. The course of the catheter, like we have already discussed, either through nose or mouth, it passes via esophagus into the stomach. What is the ideal tip position of gastric feeding tube? It should be well within the stomach and preferably in the gastric body. Ideally, the literature also mentions that the tip of gastric feeding tube should be at least 10 centimeter beyond the gastroesophageal junction in order to prevent or avoid aspiration. What happens if it is malposition? So if it is in the esophagus, the risk of aspiration will be higher. If it is in the airway or lungs, it might cause lung injury, serious complications such as pneumonias. If it is very distal, it might go into duodenum, then that will cause unintended post pyloric feeding. If it can get coiled or kinked in esophagus or also in the stomach, that will cause ineffective feeding or blockage. Okay, this is the schematic representation of nasogastric tube, and this is if you insert it via mouth, you can call it orogastric tube. Okay, now coming to the second part, esophageal stent. The uses of esophageal stents are basically for the palliation of malignant esophageal obstruction, sealing of tracheoesophageal fistulas, management of benign as well as malignant strictures of the esophagus, and sometimes also in cases of esophageal surgeries, it can also be used to prevent post-operative leaks or perforation. The course of the esophageal stent is it is introduced under endoscopic or fluoroscopic guidance, pass through the esophagus across the stricture or lesion, and stent is deployed at the level of narrowing. You should be knowing that the middle portion of the stent should be at the point of maximum narrowing or stenosis. Okay, the ideal position is centered over the lesion or stricture. Adequate proximal and distal coverage should be there, right? And it should be fully expanded to give a good luminal patency. What happens if it is malposition? If it is malposition, if it is too proximal, then it can cause persistent distal obstruction or dysphagia. If it is too distal, it can cause inadequate coverage of the lesion or fistulas. It sometimes it can also migrate. If it migrates, then it can cause obstruction or any recurrent symptoms due to underlying esophageal pathology. Sometimes airway compression can also cause, which and because of that, patient might have cough, respiratory distress. Sometimes esophageal stent can also cause pressure necrosis of the esophageal wall, which can cause perforation and bleeding. Okay, now this is the radiograph which is showing esophageal stent. Now coming to nasojejunal tube. So the uses of nasojejunal tube are, it is basically put for the enteral feeding when the gastric feeding is not suitable. Now what are the things where gastric feeding is not suitable? Where there is increased risk of aspiration, or where the patients have gastroparesis or pancreatitis that will prevent gastric emptying and subsequently will lead to aspiration in the lungs. Okay. Sometimes nasojejunal tube can also be used to bypass stomach, which reduces the risk of reflux and aspiration. The course of the catheter ideally inserted through the nose, then it goes via nasopharynx into the esophagus, via esophagus into stomach, then across the pylorus into duodenum and then jejunum. Okay. The ideal tip position of the nasojejunal tube should be in the proximal jejunum beyond the ligament of Treves. Okay. If it is malposition, if the tip of the nasojejunal tube is seen in the stomach, then it can cause increased risk of aspiration, like we have discussed. The whole purpose of putting nasojejunal tube is to reduce the risk of aspiration. Okay. It can cause ineffective jejunal feeding. If it is in the duodenum, then the risk of aspiration might be there, but it will be of the reduced. The frequency of aspiration will be reduced, and the nasojejunal tube will not work to its full capacity. If it gets coiled into stomach or esophagus, obviously if you're whatever you are going to give via nasojejunal tube, it will not be able to pass. So patient might develop, there might be some feeding failure, and there are increased chances of reflux again. If the tip of the nasojejunal tube enters into the airway, then it can cause pneumonitis or lung injury. This is the radiograph showing nasojejunal tube. You can see the nasojejunal tube is going from esophagus, gastroesophageal junction across the stomach, duodenum, and the tip is very beyond into the proximal duodenum through the ligaments of Treves. Now the next line is the next tube is percutaneous endoscopic gastrostomy tube, which is known as PEG tube. So the uses of PEG tube is for the long-term enteral feeding, for medication administration, and also for gastric decompression. The course of the catheter is you insert it via the anterior abdominal wall, and the tip of the tube should directly pass into the gastric lumen. And there are two bumpers, internal bumpers over the stomach side and external bumpers on the skin. So the bumpers will keep the tube taut and keep both the walls of the stomach as well as anterior abdominal wall in close contact. Okay, so that will reduce any tension over the stomach wall. Okay, then ideal tip position, the tip and the internal bumpers should be well within the gastric lumen and occasionally along the usually along the greater curvature and the body of stomach. What happens if it is malposition, sometimes instead of going into the gastric lumen, it can go into the peritoneal cavity, and it can cause wrong administration of fluid through the percutaneous endoscopic gastrostomy tube into the peritoneal cavity, and the patient might land into peritonitis. Okay. Then the second is dislodgement into abdominal wall. Sometimes what happens, the tip might end into the anterior abdominal wall. So whatever you are going to inject from the outer tube, outer opening, it will get accumulated into abdominal wall. So there will be swelling of the anterior abdominal wall, some superadded infection. Patient might develop abscess. There might be feeding failure, infection. What happens if the bulb of the gastrostomy feeding tube migrates into the duodenum? If it migrates into the duodenum, then it causes dumping diarrhea. I'll explain you the pathophysiology behind it. So what happens if the balloon migrates into the duodenum? If it is lax, then it can cause occasional obstruction of the duodenal lumen. Okay, whatever the patient is having, there will be no gastric emptying. Okay, and whatever you are injecting via the outer lumen of the gastrostomy feeding tube, it will not pass into the duodenum. Okay, but sometimes and this obstruction is intermittent, it will not be continuous obstruction. So as and when the obstruction relieves, and if you are injecting something, then the hyperosmolar contents of the PEG tube will enter into the duodenum, and because of the hyperosmolar contents, the patient will have increased diarrhea. It will, the hyperosmolar content will, because of the osmosis, it will suck all the body fluid and patient will have dumping diarrhea. So that is the pathophysiology. So what you can do in such cases, you can simply slightly pull out the gastrostomy feeding tube, the balloon of the gastrostomy feeding tube over here, or the just at the level of anterior abdominal wall, so that the wall of the stomach should oppose to the posterior aspect of the anterior abdominal wall. And what happened, the another complication is buried bumper syndrome. So I told you there are internal bumpers and there are external bumpers. The internal bumpers will keep the gastrostomy balloon inside the gastric lumen. So as the name suggests, there will be buried bumper. So that means there is excessive tension. The tube is very taut and there is excessive tension. So what happens, because the bumper gets buried into the gastric mucosa, and simultaneously there will be pressure necrosis of the gastric mucosa, and along with the bumpers there are higher chances of the balloon of the gastrostomy feeding tube also entering into the gastric mucosa. So whatever you are going to inject through the outer lumen, it will get accumulated within the wall of the stomach, not within the gastric lumen. So patient will develop a collection within the gastric lumen. There will be pain, blockage, there will be feeding failure. Associated infection can also be there in those cases. So you need to see whether the patient is suffering from any buried bumper syndrome or dumping diarrhea. This is the schematic representation of the percutaneous endoscopic gastrostomy tube, and this is how it will appear on the radiograph. Okay, this is the X-ray location of the stomach. You can see the bulb of the gastrostomy feeding tube over here, and this is the outer lumen of the gastrostomy feeding tube. Now coming to the gastric banding. So regarding gastric banding, this radiograph has been asked in the previous examination as far as the FRCR shorts part of the examination is concerned. So what is the use of gastric banding? So gastric banding is basically used as a part of bariatric procedure where the patients want to lose weight. Okay. So what it does, it restricts the food intake by creating a small proximal gastric pouch. So this is the gastric banding. So this is a schematic diagram where you can see the distal esophagus, gastroesophageal junction, proximal portion of the stomach. Then this is the rest of the stomach. This is pylorus. This is first part of duodenum, second part of duodenum, and this is the gastric banding. Okay, this is how they will apply the band over the proximal portion of the gastric proximal portion of the stomach, where they create a false lumen of the stomach over here. And whenever the patient eats something, it will cause a pseudo feeling that because of the distension, it will the stomach will give a pseudo feeling that it is full, and patient will have a satiety and patient will not eat further. And with this gastric banding, there is a tube connected which will come out through the anterior abdominal wall, and this is the port, this is a pump, and with this patient can increase the pressure, decrease the pressure accordingly. So if the patient, by pumping, if the patient increases the pressure, then it will further narrow down. Okay, and it will cause iatrogenic narrowing. It will cause, basically it causes a neo stomach over here. So what is the course of the tubing? So this is a silicone band placed around the proximal portion of the stomach, just below the gastroesophageal junction, connected via tubing to a subcutaneous access port, usually through anterior abdominal wall for adjustment. The ideal position is band lies obliquely. So the question was asked based on this, the phi angle. It should be, the normal phi angle should be 4 degrees to 58 degrees. Okay. So the band lies obliquely around the gastric fundus, forming a small pouch over here. And on the X-ray, the phi angle should be between 4 degrees to 58 degrees. The band, I'll tell you how to measure the phi angle in the next slide. And it should appear as a rectangular ring-like structure in the left upper quadrant of the abdomen. Now, what happens if it is malposition? If the band slips, then it will cause enlarged gastric pouch. If it is slips, if it goes down, then the proximal portion of the stomach will be enlarged. it will sometimes it can also cause a risk of obstruction. If the band is too tight, then the patient might develop operation necrosis, dysphagia, vomiting. Band erosions can happen. Similarly, the mucosa might undergo necrosis. Incorrect angle can cause migration or improper placement and can lead to reflux pain and inadequate weight loss. Now, how to measure phi angle? So, phi angle is usually measured. So, this is the gastric banding. So, phi angle is, this is the phi angle. You need to draw a vertical line parallel to the, in the mid portion of the spinal column, and you draw a line which is parallel to the gastric banding, and this is the phi angle. Okay, the phi angle should be 4 degree to 50 degrees. Okay, in the exam they might give you this gastric band lying over here, so the phi angle will come around 90 degrees. Okay, so if it is 90 degrees, then there will be a slippage of the gastric band. So you need to mention about the phi angle in the examination. Okay. Now coming to the last part, pigtail or abdominal drain. If the abdominal drain pigtail catheter is usually put in cases of intra-abdominal collection such as liver abscess or abscess in the rest of the abdomen. If there is any fluid they want to drain, or any collection of the bile or collection of the urine, it is usually also put in post-operative fluid drainages. It is done under image guided, usually CT guided or ultrasound guided for the therapeutic decompression. The course of the catheter is inserted percutaneously under USG and CT guidance, traverses abdominal wall into the peritoneal cavity or into the targeted collection wherever you are going to put the tip of the pigtail catheter, and the curled pigtail ends locks within the collection. So sometimes patient might have habit of pulling the catheter outside, but because of the curling, because of the pigtail, it limits any further movement. Okay, the ideal tip position, the pigtail should lie within the central portion of the collection. The side hole should be into the fluid cavity, not in the abdominal wall. So what happens if malposition, if it is outside the collection, then basically logically there will be no drainage or poor drainage. If it is in the bowel, sometimes the pigtail catheter might go into the bowel, can cause bowel perforation, or there might be a feculent output. Sometimes pigtail catheter can go into the solid organ, can cause bleeding or organ injury. Because of the pulling of the pigtail catheter, the tip might come and get itself lodged into the anterior abdominal wall or within the subcutaneous tissue, might cause ineffective drainage, pain, or possible infection. So this is the pigtail catheter put into the hepatic abscess. So we are at the end of lines and tubes as far as the adult gastrointestinal system is concerned. I'll be uploading this short presentation on this YouTube channel, FRCR Shorts. I'll also be sharing the link of the YouTube channel, also the Telegram link, where we'll be discussing cases on daily basis, the FRCR Shorts. Okay. I'm also planning to conduct shorts related exam for the exam going students only. So stay tuned. I'll be uploading few more sessions in coming days regarding rest of the lines and tubes. The Euro part is remaining, the CNS part is remaining. So yeah, good day. Bye.